Good evening to all. Today's case presentation is on wet age-related macular degeneration. 55-year-old female patient, resident of Chennai, visited to Shankara Nethralaya with chief complaints of gradual, painless, progressive diminution of distant and near vision in the right eye for last 1 month. Systemic history was relevant for hypertension, and she was on treatment for last 8 years. No other significant systemic illness in the past. Past ocular history was negative. Past family history nil significant. And allergic history not aware of. And on best corrected visual acuity on Snellen's chart, right eye showed 6/9 vision with plus 2.5 sphere and minus 1 cylinder at 90 degree. And near vision was N12 with at 2.5. Left eye showed 6/6 vision with plus 1.5 sphere and minus 0.75 cylinder at 90 degree, and near vision was N6 with at 2.5. Anterior segment of both eye was within normal limit, and pupil both eyes was round, regular, reacting to light with no RAPD, and IOP was intraocular pressure measured by Goldman applanation tonometer was 11 millimeter of mercury both eyes. This is a lens was clear both eyes, sir. Clear. 55.
Any modification of your statement is possible? For a 57-year-old lady, do you expect the lens to be absolutely normal? Clear means a 15-year-old, 20-year-old lens is clear, absolutely, right?
Yes, sir.
But a 57-year-old will have some amount of nuclear sclerosis.
Okay, sir.
It need not be called cataract.
Okay, sir.
But usually there will be at least one grade 1 nuclear sclerosis.
Okay, sir.
It's exceptional that they have crystal clear lenses like a 20-year-old, right? Yep.
This is a color fundus photo of the right eye with media clear and disc vertically oval with temporal pallor and cup disc ratio 0.4 with vessels arising from the center and branching dichotomously. And in the posterior pole, there is a yellowish membrane-like lesion, which is probably subretinal, which is surrounded by dark brownish red subretinal hemorrhage, which is further surrounded by an area of RPE alterations. And there are some well-defined yellow lesions along the vascular arcade in the superior, which can be drusen.
For the VR fellows here, VR fellows, no VR fellows, okay. What negative feature would you like to state? You obviously know what you're seeing, right? So what negative feature would you like to specifically mention? What is the predisposition before trauma? Feature. Drusen, yes. Because drusen is one of the predisposing factors, right? So is there drusen present in this eye? In this eye? Well, those are very so, right? They're hardly of any significance. So really there is no significant drusen in the posterior pole at all.
Okay.
And what you find is without drusen. So that negative feature should be mentioned, all right?
Okay.
I'm not sure whether it's a problem with the photograph or is it a fact, but you can see that inferior arcuate fibers compared to the superior arcuate fibers, there's something as if there has been a segmental segmental arcuate bundle loss, I'm not very sure, but that needs to be confirmed. Because photography can be misleading sometimes. Okay. Like you said, temporal pallor, it may not be really pallor. It's a pallor on the fundus photograph, but may not be really present, okay? Yes, so fundus photographs can be misleading sometimes, okay? What more would you comment upon in the fundus photograph? You said there's a yellowish membrane, right? I would describe it as a dirty gray membrane rather than a yellowish membrane. Yellow, I would use it to describe something like an exudates, hard exudates or a drusenide material,
Okay, sir.
I would use it yellowish. This is not yellowish. This is a more of a dirty gray membrane, right? Dirty gray lesion under the retina, surrounded by hemorrhage.
Retinal hemorrhage.
Again, VR fellow. You are the only VR fellow, is it? No, nobody else? You qualify the statement of describing the subretinal hemorrhage so that the person who is listening to you understands a little more than what has been told so far.
Sir, it will be dark reddish, dark red in color, and we can see the blood vessels going over the hemorrhage, sir.
As mentioned, you want to state to qualify the blood. Dr. Shruthi, where all can blood be present in a situation like this?
Intraretinal.
Then,
RP.
right? Is this a subarachnoid hemorrhage or a subretinal hemorrhage? The major part of it is subretinal because you see it clearly. You see it more like a brick red appearance, not a dark, dull appearance. Sub-RP hemorrhages mostly are dark and dull because they are seen through an overlying RPE. And the margins are not as crystal and crisp clear as the subretinal hemorrhage. If you see inferior to the membrane, temporal to the membrane, nasal to the membrane, most of it has got very clear borders. Okay, that's all likely to be subretinal hemorrhage. Again, it's a judgment. There could be small areas of sub-RP hemorrhage. On top of it, there may be subretinal hemorrhage. I'm not denying that possibility. For example, the small notch-like hemorrhage nasal to the membrane. Can you point this out? Beyond that, go closer to the optic disc, a little below. Yes, you see one patch which is a different color than the rest, right? That patch which is of different color could be a sub-RP hemorrhage, I'm not sure. That we will know in the OCT. But basically that's how you differentiate, okay? Subretinal versus sub-RP. But most of the hemorrhage is subretinal.
Is a color fundus photo of the left eye with media clear and vertically oval disc with temporal pallor, a cup disc ratio 0.4 to 5 with vessels rising from the center and branching dichotomously with a few yellowish lesions over the perifoveal area.
Given that one word, one sentence description, can you make out anything? It says yellowish lesions in the posterior pole. What does it mean? Would you like to qualify your statement? As I said, your description should be so good that without looking at the fundus picture, I should be able to imagine what you are seeing.
Yellowish, well-defined subretinal.
Not confluent. There is no drusenoid detachment. They're not soft drusen. So all this puts them at a low risk as far as the typical features associated with the AMD is concerned. That would be important, right? Okay. 20 years old, you said, right?
55-year old.
Okay, fine.
Next, we did fundus fluorescein angiography and FFA of the right eye in the early arteriovenous phase showed central hyperfluorescence.
Why do you say it's arteriovenous phase?
Because laminar flow in the vein.
Very good. Why is there laminar flow?
Because plasma flows rapidly along the wall because of less cellular concentration, and
the same thing holds good even for the artery.
So
Plasma goes in the center, cells go in the periphery. Why is it the laminar flow only in the vein and not in the artery? It's turbulent. That's the word you're looking at. Artery has got turbulent flow. And because flow is turbulent, everything gets mixed up. So you won't even see the front. The fluorescein front, even if you inject with bolus, you won't get the front. Everything gets mixed up. But in a vein, you can see the front, number one. But why laminar flow? Which part of the fundus is first filled up with fluorescein? Posterior pole or periphery? Posterior pole, right? So when posterior pole is filled first and periphery is filling a little later, at one point of time, the fluorescein goes through the arteriole, through the capillary, then into the venule, and comes and joins the bigger vein, right? So the feeding venule into the main vein is likely to contain fluorescein earlier at the posterior pole. which means if you the blood towards the periphery of the blood column in the vein near the disc is contributed by blood from the posterior pole, and the central part is from the periphery. Is that clear? Or you have a doubt? இங்கே போர்டு கிடக்கமாங்க தம்பி, எக்ஸ்கியூஸ் மீ
Brother,
இங்கே போர்டு எதுன்னு இருக்கா ட்ராயிங் பண்ணதுக்கு? போர்டு கிடையாதா? Or okay, let me explain with this. Now you have this vein, right? The flow is from the periphery towards the disc, right? If these veins are joining here and these veins are joining beyond, the blood from this vein is likely to be in the periphery and the blood from this side is likely to be in the center. This is simple logic, right? So, since the blood that has come out into the posterior pole is first with fluorescein than in the periphery, and since the blood which has entered the venule in the posterior pole also gets first filled up with fluorescein before the periphery, so the blood coming back from the vein in the posterior part is likely to contain fluorescein first and not the blood in the center which is coming from the periphery. That's why you get the laminar flow. So the side is becoming fluorescein stained, but center is still not stained with fluorescein because central blood is coming from periphery, which is still not got the fluorescein. That is the cause for laminar flow. Okay? Two reasons why you get laminar flow. One is the relative absence of fluorescein in the blood coming from the periphery and lack of turbulence in the vein compared to arteriole. Is that clear? All right. Go to the next point.
Fundus fluorescein angiography shows fluorescent area in the center suggestive of activity surrounded by blocked fluorescent, which can be due to subretinal heme, which is further surrounded by a relative hypofluorescent area, which can be due to RPE alterations. Coming to the venous phase of FFA, it shows increase in hyperfluorescence with leakage surrounded by blocked fluorescence, which is surrounded by further area of hypofluorescence.
See, I don't think you can make a conclusion as to the cause of the hyperfluorescence surrounding the hypofluorescence till we see the entire picture, including the OCT. Okay, we can't see it's due to RPE alone. Okay, there may be a trace of subretinal fluid surrounding it, into which the fluorescein may be leaking. We don't know. Let us see the full angiogram, then we conclusions. Here we discuss hyperfluorescence and then see.
Towards the late phase, there is staining of tissue, which is surrounded by blocked fluorescence. Coming to fundus fluorescein angiography of left eye, there are some small hyperfluorescent spots which can be due to drusense, and rest of the fundus fluorescein angiography was within normal limit. Is the vertical section of OCT right eye with an area of subretinal lesion of variable reflectivity with increased thickening and some cystic spaces with an area of hyporeflectivity, which can be due to subretinal fluid. And
is there any retinal thickening?
Subfoveally.
So there is some amount of retinal edema as well. It's not that the retina is compact. Okay. In addition to the subretinal lesion, which is of variable reflectivity, you also see some amount of retinal edema. Okay, and subretinal fluid. All right.
Left eye OCT was within normal limits. Fundus fluorescein angiography and OCT findings of this patient. He was diagnosed as having right eye wet age-related macular degeneration with active.
Just a small addendum that when you're explaining to the patient, using the word wet and dry is easy. But when you're explaining to your colleagues or to ophthalmologists, we don't use the word wet AMD. You can use it, but more better is neovascular AMD, okay, rather than wet AMD.
Neovascular age-related macular degeneration with subfoveal active choroidal neovascular membrane and left eye.
What type of membranes? What are the types of CNVM associated with AMD?
Type 1, type 2, type 3. Based on FFA, it's
Is this type 1 or what you're seeing?
type 2, sir,
Why do you say type 2?
because it is subretinal.
Both are subretinal. Nothing is preretinal. Even type 3 is subretinal.
Sub-RP is type 1.
Is it pre-RPE or sub-RPE, this
PRP.
membrane?
PRP is
Why do you say it's pre-RPE?
neurosensory retina and retinal pigment epithelium.
Okay, on angiography, what are the features of a pre-RPE membrane?
There is a lazy pattern of hyperfluorescence in the early phase, which leaks in the late phase with staining in the.
So early filling of the membrane, where the entire, so early filling of the membrane, starting from the periphery towards the center, and entire membrane gets stained up later on very quickly, and then of course leakage. These are the features of pre-RPE membrane or type 2 membrane. Sub-RPE membranes tend to fill up later because they're covered sometimes by fibrin, blood, RPE and so many things, and hence they don't show up immediately after you inject the dye. They take a little time to be visible, and then they're not visible sometimes as clearly as you want it to be seen, and that's why you got the two ways of manifestation, right? Fibrobascular PED and leak of unknown origin. Leak of unknown origin is just suddenly you find over a period of time the whole thing becomes diffusely stained. We don't know from where it started to leak, so you can't identify the actual neovascular process from that type 1 kind of membrane. Sometimes fibrobascular PED is basically you see PED, pigment epithelial detachment, with a lot of fibrosis and also vascularity, and so those produce patchy hyperfluorescence which tends to leak in the late phase. Okay, that is type 1 membrane. This is note, so it should get imprinted in your mind how a type 2 membrane looks like. Earliest phase. See, now this is not so characteristic of the early filling of the edges. Membrane seems to be having roughly the same kind of hyperfluorescence, right? But very often in a typical 2 membrane seen in, say, idiopathic CNVM or post-traumatic CNVM or post-inflammatory CNVM, younger people, you will find that the edges become hyperfluorescent first, then slowly the center becomes hyperfluorescent. It's so. Why is that behavior? Edges becoming first hyperfluorescent, then the center. The whole thing is right. Then go from periphery to center. Fear and go for center. Yeah, that is the most important point. So most recently formed vessels on the edge of the membrane, right? So they are leaky, they are least mature, they are probably some endothelial cell tubes, nothing else. So they leak much more than the central vessels which are already becoming relatively mature. That is why you get maximum leak at the edge, like a frill, and the center becomes less leaky. All right? Okay, go ahead.
Patient was advised intravitreal injection, anti-VEGF injection under topical anesthesia, and she underwent right eye intravitreal Lucentis ranibizumab injection.
We usually don't tell ml, we tell milligrams. Because you can inject the same drug if you add some more distilled water to it in 0.1 ml also, right? So you tell in milligrams.
0.5 milligram.
All right, 0.5 milligrams.
After 1 month, right eye vision slightly improved, but as choroidal neovascular membrane was still active, she was advised to go ahead with.
Okay, stop here. Would you find fault with that statement? Who else is the VR fellow here? You're all VR fellow? That's okay. That's okay. I'm not worried about it. I'm not splitting hairs. I'm trying to, for you to understand what is wrong with the statement. Would you inject only if CNVM is active after first month? There is something called loading dosage, right? So irrespective of the presence of activity or otherwise, you would still have injected 3. That is called loading dosage, right? So you are not injecting every month based upon the activity. Okay, first 3 months you have to inject unless the patient doesn't want it. Okay? Yeah, go ahead.
She has received only 2 injections and patient came for follow-up after 2 months, and the vision was the following. Right eye showed 6/6 vision with plus 1.75 sphere, and near vision was N6 with at 2.5, and left eye vision was 6/6 and N6, and intraocular pressure was both eye 16 millimeter mercury.
I'm a little puzzled because the cylinder seems to have gone off, you know. Why did it disappear? I don't know. All right, that's the problem with refraction. Okay.
OCT showed
Before OCT, why don't you describe the fundus? It's also available there. You compare the two and tell.
reduced hemorrhage.
Okay. There is resolution of the subretinal hemorrhage. Okay. The membrane also appears a little more compact and little less than above, although direct comparison is not possible, just impression. Now you can tell about OCT. What do you see?
Showed reduced thickening with resolution of subretinal fluid.
If you see the picture above, okay, is there a pigment epithelial detachment in the picture above? Be very sure. I agree. It's a little ambiguous because if you see this, it is nothing but reflectivity. Even a thick fibrotic lesion can also produce a red reflectivity, but this is quite a bit of continuity is seen. So it's possible that this is the pigment epithelium, and this is probably sub-RPE space, and this is the pre-retinal pre-RPE membrane. Okay? There could be a component of pigment epithelial detachment as well. I don't know. Now here, if you see, this seems to be continuing as a pigment epithelium. Okay, although there is some amount of shadowing here caused by this thick scar, thick fibrosis, and hence you cannot see the RPE here. But it's more likely that RPE is here and not here. Okay, but still it is possible that this could be the RPE and this could be actually the sub-RPE space. Okay, but more likely that this is RPE, but this is still congenital. Okay. That's why it's very important that we always scroll through the entire frame, entire scan, and come to conclusions, not based upon one picture. One picture it's always confusing. Okay, you can make mistakes. So you always scroll through. You go to the machine and go through, and always use grayscale. Never use this artificial coloring. Why is grayscale better than artificial coloring? Artificial coloring looks nice for the patient to see, okay, but not for you. Why is it so? Why is grayscale more important?
The layers are well defined in the grayscales.
What is altered between grayscale and color? How is the coloring given? See, grayscale is a continuum between X decibels to Y decibels. It's a continuum, okay, at intervals which the machine is capable of collecting information about. While artificial coloring, you collapse the information. It's like having class intervals. How many of you know statistics? A little bit of statistics, not too much. You know what's the class interval, right? What is the class interval?
So, 10 to 20, 20 to 30,
Yeah.
30 to 40.
Okay, so means you collapse information into more easily understandable and more easily realizable intervals, right? This is like creating class intervals. So he says green is between this much decibel reflectivity to this much decibel reflectivity, and suddenly it becomes yellow, suddenly it becomes red. It's not sudden. Grayscale is a continuum. So when you put it in grayscale, you don't lose that information. You're able to judge much better the subtlety of the variation of the grayscale. But when you look at the color picture, you lose that information. Either it is red or yellow, nothing in between. Okay? Yeah.
Yes, sir.